Hi, I'm Dr. Venkatesh. I'm a consultant neonatologist. Today I'm discussing about a preterm neonate referred to as with post-hemorrhagic ventricular dilatation. Around the complication of post-hemorrhagic ventricular dilatation. This topic is very important because if we do not treat in time, it will lead to the further deterioration of the brain function. The post-hemorrhagic ventricular dilatation is mainly due to the loss of the brain matter, the parenchyma, especially the white matter, causing ex vacuo ventriculomegaly. When the baby was referred to as, the history was baby was born at 25 weeks of gestation with a weight of 600 grams, required intensive resuscitation at birth, connected to the ventilator in the newborn intensive care unit, received surfactant administration, and within 24 hours, the cranial ultrasound was performed, which demonstrated grade 3 intraventricular hemorrhage. The serial ultrasound was performed every day to look for any further bleed in the brain and also to look for evidence for post-hemorrhagic ventricular dilatation. On coronal view of the brain, we could find that the ventricular index given by Levene and the anterior horn width, the diameter in millimeter, they exceeded very high. If you look at the graph, they exceed almost 3 times the maximum limit on the graph that you see when you plot the ventricular index on y-axis and postmenstrual age on x-axis. In both ventricular index and anterior horn width, they were very high, the millimeter very high, almost 3 times the maximum limit that you can see on the graph. Parasagittal view of the brain also was performed to look for thalamo-occipital distance, which also was very high. Here also it was plotted, the y-axis was thalamo-occipital distance and the x-axis was postmenstrual age. Then the parents were counseled regarding the drainage of the CSF fluid. Because this baby was very small, around 1 kilo, ventricular peritoneal shunt could not be performed. But the dilatation was so huge, there was a necessity of draining this fluid. The subgaleal shunt was performed after performing the CT scan of the brain. This subgaleal shunt lasted for 2 to 3 weeks. Again, there was accumulation of CSF in the brain. The ventricles started dilating again, and then again the family was counseled. We had to put the reservoir, the shunt reservoir, and couple of days after the reservoir insertion, the ultrasound cranium was performed to look for the ventricles. Meanwhile, baby also started to develop apneic episodes, and again the ventricles started to dilate. It was around 24 millimeter. So, because the reservoir, we could aspirate around 20 to 25 ml of CSF from the reservoir. This actually helps for the baby, one, to grow, because the VP shunt usually will be found once the fat is found well. It's around 2 kilos, 2.5 kilos ideal time for the ventricular peritoneal shunt. Until that point, by the time the reservoir is there, we can directly tap, we can insert a butterfly needle into the reservoir and we can drain the CSF, and it is easy to demonstrate whether the ventricles are filling or not by performing serial ultrasounds. When we did resistive index before the drainage from the reservoir, it was around 8.54, and as soon as around 25 ml of CSF was performed, there was sudden increase in the diastolic flow. As you see, the resistive index came down to 5.54 almost. So my friends, a small baby with a big head and the ventricular peritoneal shunt cannot be done at this moment, and the reservoir, especially the reservoir shunt or subgaleal shunts, these are only two options we have at this moment to keep draining the fluid temporarily. Of course, the serial examination of the baby, the neurological assessment of the baby, clinical condition of the baby is very important. Of course, while dealing such a small baby with a big problem without knowing the neurological outcome, the essential part here is, one is on one side dealing with the clinical condition and performing what is required, and the other side is counseling the parents, very important. So counseling the parents regarding the long-term neurological outcome. Here in our index case, parents were counseled about the long-term neurological outcome and also the acute survival at one point of time, but the parents wanted everything, the best treatment that can be provided to this baby. So at this moment, baby is on CPAP and the reservoir is in situ, and then we are draining the fluid as and when there is a requirement, waiting for the baby to gain weight. And adequate nutrition is very important. Here we are providing what best nutrition we can provide to this baby. Thank you so much.